Effectiveness of SBIRT in the Emergency Department, a DNP project by Leah Joslin. Committee members include Dr. Elizabeth Buck, Chair, Dr. Boniface Stegman, Second Reader, and Amanda Schertz, Community Member. The Screening, Brief Intervention, and Referral to Treatment, or SBIRT, initiative began statewide in New Mexico in rural health settings in a study looking at over 52,000 adult patients over a 5-year period that demonstrated that this program is possible to implement in rural settings. There is limited research on using this method for all arrivals to the ED and no studies utilizing the specific HLQ screening tool that will be utilized for this project. It is proposed that this project will provide significance to nursing, including the patterns of knowing proposed by Chin and Kramer that inform nursing practice, significance to healthcare through reduced utilization, as well as having a direct impact on the global substance use disorder epidemic. The SBIRT process follows the nursing process through assessment of current health status and readiness to change, diagnosis, motivated or resistant, planning, collaborative and patient-driven, implementation or intervention, patient actions and nurse reinforcement, and evaluation, collaborative, goal attained or not. A part of the call to action in the Future of Nursing 2020 to 2030, Charting a Path to Achieve Health Equity, is for nurses to provide services and care to reduce substance use disorders. APRNs are often focused on holistic patient care, and integrating SBIRT into practice aligns with this approach, particularly in the ED setting, where the clinicians are addressing the physical health of the individual as well as their mental and psychosocial needs. SBIRT fosters a team-based approach to care and allows the APRN to participate as part of an interdisciplinary team. SBIRT enables early detection of substance use disorders and those who demonstrate substance use disorder risk before they can escalate into more severe conditions. Patient outcomes are improved through decreased substance use and enhanced mental and physical health outcomes. Central to one of the aims of this project is the potential to reduce healthcare utilization through fewer ED return visits and thus improving the allocation of resources towards prevention and recovery. From a public health perspective, SBIRT has the potential to decrease rates of substance-related injuries, overdoses, and fatalities, as well as improve the community's well-being and safety. In total, 561 articles were generated in the initial search of the SBIRT and related terms. After filtering to include only those articles with project subject terms, a total of 14 relevant primary search publications for this literature review were selected. Avalone et al. Looked at 11 different emergency departments in New York City and found that 45% had documented alcohol use disorder and 74% of patients overall had documented substance use disorder. SUD is seen frequently in those with comorbid mental health diagnoses. 36.7 to 40% of those with mental illness report drug use in the last year. SBIRT, developed in 1960, is a universal clinical approach to address and manage substance use disorder risk regardless of evidence that indicates substance use or abuse exists. SBIRT, deployed in a variety of healthcare settings, is a valid model or tool to identify SUD, reduce healthcare utilization, decrease the frequency and severity of illicit drug and alcohol use, and increases referrals to treatment. Many screening tools adopt portions of other screening tools and incorporate them into the development of a new tool. The GAD-7, Audit, DAST, and PTSD-5 are all screening tools used in the development of the HLQ screening tool for this project. Early identification of anxiety could be significant in identifying individuals who are at risk for developing SUD. The Generalized Anxiety Disorder, GAD-7, is a quick, free screening measure that can be utilized in many settings and adapted to several languages to gauge anxiety experienced in the previous 2 weeks. The Alcohol Use Disorder Identification Test, Audit tool, is valid and reliable with demonstrated effectiveness when used within the context of the SBIRT model. The HLQ used for this DNP project utilizes the 3 questions from the audit screening tool, which correspond to questions 9, 10, and 11 of the HLQ. Drug abuse screening is necessary to provide early identification of substance use disorders in those individuals who may need treatment and resources. The drug abuse screening test, DAST, is valid and effective within the SBIRT model. Questions 12 and 13 from the HLQ are adapted from question 1 of the DAST. Exposure to traumatic events and the related long-lasting mental health consequences is a commonly shared global experience. PTSD-5 is adaptable and translatable to different cultures and delivery settings. It is valid and reliable with moderate sensitivity and high specificity, particularly in emergency contexts where time constraints and resources are often limited. SBIRT is a frequently used method for understanding substance use disorders and can be utilized in several settings. Outpatient and primary care settings demonstrate high utilization of the SBIRT model. The rural healthcare setting presents unique challenges that may not be present themselves in larger, more urban settings. Only one study reviewed was conducted in a rural setting. The literature indicates that SBIRT effectively increases screening, identifies substance use disorders, and increases brief intervention with motivational interviewing. SBIRT was also effective in generating a referral to treatment and follow-up. With respect to utilization, Pringle et al. Demonstrated a 21% reduction in healthcare cost utilization, reducing 1-year emergency department visits by 3.3% and a 4.1% decrease in inpatient claims. IRB oversights and approval, disclosure of conflicts of interest, large sample size, study design, such as an RTC, use of comparison groups, consistency with design to reduce variables, consistency of valid screening tools, and follow-up after intervention were all strong characteristics of many of the studies reviewed. Study design related to the frequency of data collection, retrospective nature, or lack of rigorous methods to analyze data could be considered a weakness. Half of the studies contained sample sizes of less than 500 individuals. Many of the studies demonstrated demographic weakness by limiting ages and potential influences on the study in the forms of bias due to race, ethnicity, or gender. Finally, no study examined utilized the HLQ as a screening tool. Gaps in the literature include examining the barriers to follow through after receiving a referral to treatment, whether the payer's ability to pay alters motivations to change, and whether socioeconomic factors change behavior and readiness. Additionally, few studies have been done in the ED focusing on reducing potential ED visits. One of the more significant gaps and inconsistencies in the literature is the delivery of the screening tool. Self-reporting was done in several studies where results could be influenced by the participant recall or social desirability. However, it is the most widely used strategy for screening tool delivery due to time constraints and limited resources in the ED. The final gap in the literature is the cost effectiveness of SBIRT services, looking at SBIRT service implementation compared to the cost savings related to repeat ED utilization after successful SBIRT intervention. There are many limitations to each of the studies reviewed in the literature regarding the nuances of SBIRT characteristics and screening. When examining inclusion and exclusion criteria, many of the studies only examined alcohol use and abuse without consideration for other illicit drugs. Carno et al. Excluded those who had unstable living conditions, had already received treatment in the past 90 days, or individuals with any history of documented substance use disorder. Other studies excluded those individuals requesting the alcohol treatment, those with language barriers, or individuals in custody. Alternatively, many studies limited inclusion criteria to adolescents, those with mental health diagnoses, trauma-specific individuals, or HIV-positive individuals only. 2 of the studies, Avalone et al. And Lowenstein et al., had their own substance use disorder treatment programs or had previously implemented treatment guidelines. Lack of generalizability was found in over half of the studies. Paltzer et al. Were limited in that the study was carried out in the state that demonstrates higher substance abuse rates than the national average. Similarly, Lowenstein set their study in an area with the highest rates of overdose deaths in the U.S. Carno et al. Limited their study to the psychiatric setting and thus may not translate to a general ED setting. Limited time in terms of study hours and/or days was present in several studies, and it is not translatable to settings with 24/7 interventions such as an ED. This DNP project, which focused on implementing the SBIRT model in the ED, is represented most by the trans-theoretical model of behavior change, or TTM, developed in the 1970s by psychologists James Prochaska and Carlos Di Clemente. The authors of the TTM posit that individuals progress through 6 stages of change: pre-contemplation, contemplation, preparation, action, maintenance, and termination, and that the clinician can guide an individual through these stages. Motivational interviewing, a vital component of the brief intervention (BI) component of SBIRT, adopts aspects of this model to develop the SBIRT process. In the TTM stages, pre-contemplation, contemplation, and preparation are 3 stages where SBIRT can target and have the most significant impact. In the pre-contemplation stage, the individual is unaware of their problem or is not considering behavioral changes. Screening can help individuals realize that they may have a problem or are at risk for developing a substance use disorder. The clinician can then guide them towards acknowledging the problem and gauge if they are ready to make any change. In the contemplation stage, the individual weighs their pros and cons and considers making a change. This stage is where MI within BI is critical. The clinician can guide the individual to identify what pros exist and make a change towards a treatment that benefits them. Finally, those in the preparation stage are actively planning to act and may need guidance and resources to take that step. MI can reveal that a person is at this stage and that the clinician is in an ideal position to offer those resources and referrals. The fact that this model was created for use in individuals with addiction confirms its relevance and importance as the theoretical foundation for the project. This quality improvement initiative used a retrospective, quantitative, exploratory method to determine whether the intervention was effective and statistically significant. Before this quality improvement project, there were no measures in place to screen for substance use disorders or a means to provide intervention and/or referral to treatment. Electronic health records, EHRs, from a rural critical access hospital in the southwest region of the United States were utilized for data collection. The project was launched on February 17, 2025 through August 17, 2025. The minimum necessary data to accomplish the goals for the project was collected on the data collection sheet, and all patient identifiers were removed and remain uncollected for this project. No pre-implementation data was collected. The post-intervention data collection sheet contains information pertinent to this study, such as the patient's demographic information, age and gender, arrival, chief complaint, medical or psych detox, if the HLQ was completed, if the HLQ was positive, if brief intervention, BI, was completed, and if there was a referral to treatment, RT. Additionally, the author documented whether those who received a referral to treatment returned to the ED for a substance use disorder related complaint. The project used nominal scales to code responses and demographic data. The nominal values include 1 for yes, 2 for no, and 3 for not applicable. When collecting demographic data, numbers were used to code age ranges. 1 equaled 18 through 24 years of age, 4 equaled 61 through 89 years of age. And the same was done for gender, where 1 is female and 2 is male. Developed based on quantitative judgments, all questions and data were collected in this nominally scaled fashion. The nominal data collected to evaluate the effectiveness of SBIRT implementation were analyzed through descriptive statistics and frequency distribution. Descriptive statistics were used to assess the demographic data of the post-intervention group. The distribution of gender and age are detailed below. In total, there were 5,417 participants, with the sample remaining consistent with regional demographics, thus concluding this was a representative sample. The nominal data collected to evaluate the effectiveness of SBIRT implementation were analyzed through descriptive statistics and frequency distribution. There was no control or pre-intervention group, and as such, causal conclusions cannot be drawn. Effectiveness was substantiated by the researchers' chosen data collection method and analytical approach, which is suitable for the hypothesis tested. The intervention was deemed effective due to the fidelity to the SBIRT process that was significantly improved, and the incidence of both detecting at-risk SUD individuals and returning SUD-related visits to the ED was reduced, demonstrating a correlation and improved patient outcomes. Variability cannot be calculated statistically, as there is no mean, median, or standard deviation for nominal data. Variability in this quantitative study was captured by purely analyzing the range of characteristics within the data, including frequency. Frequencies and percentages were calculated for each chosen variable, including completion of the HLQ, scoring of the HLQ, and subsequent BI and RT among the patients. The sample consisted of 5,417 adult patients, with a significant portion, 5,117, arriving for complaints unrelated to substance use disorders. Of those individuals screened with the HLQ, 66.2% of all arrivals, or 1,278, screened positive. Of that, 85.7% were in the ED for chief complaints unrelated to substance use disorder. This is significant in supporting the effectiveness of SBIRT at identifying those individuals with SUD risk. The next step in the SBIRT protocol included BI and RT, in addition to understanding if those who received RT subsequently returned to the ED for substance use disorder related complaints. Data indicate that a staggering 89% did not return to the ED for SUD complaints after receiving an RT. 43% of those individuals who received a referral to treatment and subsequently returned to the ED had also originally come to the ED seeking substance use disorder treatment. This suggests that utilization by those at highest risk for SUD was potentially reduced by 57%. Variables such as seeking treatment elsewhere, remaining in treatment during the study period, returning after the study period timeframe, or another factor may be contributing to the ED utilization after a referral to treatment. In a quantitative retrospective exploratory design, limitations are inherent due to the reliance on previously collected data and the analysis being limited by the accuracy, completeness, or consistency of existing records. This is true when analyzing why BI completion was noted as not applicable. The denotation could relate to the patient not scoring high enough on the screening to warrant BI, the patient refusing BI, the acuity level changing, and staff being unable to complete the BI, or perhaps non-compliance with the SBIRT process. The greatest limitation is that retrospective designs cannot establish true causal relationships, and only associations can be identified. As there was no pre-implementation data collected, there is no statistical significance that can be identified or measured. Additionally, variations on how staff recorded screenings, interventions, and referrals may have affected data consistency. Finally, data was drawn from patients arriving at one ED and one rural critical access hospital, which may limit the generalizability to other healthcare settings or populations. There are numerous explanations and considerations for the discrepancies between the observed and expected outcomes of this project. Staff did not consistently follow all components of the intervention, particularly at the beginning of implementation, citing lack of time, competing priorities, lack of understanding, and lack of reinforcement. Inadequate training on the intervention, specifically with contract staff, led to inconsistent application. The intervention was not integrated into the existing EHR, leading to decreased efficiency and a lack of adherence to various steps. High workload in the ED and fatigue decreased engagement and reduced the quality and frequency of intervention delivery at times. It is suspected that due to the population in the community, there were transportation barriers and social instability that may have reduced compliance with referrals, resulting in return visits to the ED for substance use disorder related complaints. Limited community service for referrals may have also reduced successful linkages. Additionally, some measurement sensitivity was lacking, where qualitative improvements in patient understanding did not appear in the quantitative data. Expected outcomes, specifically as they relate to healthcare ED utilization, may not have been fully captured, as they may take longer than 6 months to manifest, which this project timeline did not allow. In terms of design limitations, behavioral and system level changes typically require a sustained effort and reinforcement. The short project period likely did not capture the full effect. Differences between observed and expected outcomes in the SBIRT implementation in the ED often arose from a combination of human, environmental, organizational, or measurement factors. Understanding these differences lays the foundation for sustainable improvement and future implications. The findings from this SBIRT project highlight several implications for future research, particularly the need to bridge the gap between evidence-based models and actual clinical practice. In terms of nursing practice, SBIRT expands the nursing role and engages nurses in prevention-focused assessments and interventions, rather than only responding to acute crises, particularly with ED nurses who are adept at primarily managing acute crises. Additionally, SBIRT fosters therapeutic communication and empathy, thus strengthening the nurse-patient relationship and improving rapport and trust. Interprofessional collaboration allows nurses to become a part of the coordinated care model with social workers and community health workers to improve continuity of care. Early intervention can reduce repeat ED visits and workload associated with substance-related emergencies. In terms of community implications, an SBIRT project improves public health outcomes through the reduction of SUD rates, overdoses, and related injuries, as well as enhancing accesses to care. Rural areas often lack resources for substance use disorder. SBIRT creates a bridge between acute care and long-term treatment by connecting patients with needed services they may otherwise be unaware of or have limited access to. Working with local boards of nursing to encourage inclusion of implementation-specific competencies in professional education and continuing education credits for licensure is an avenue for widespread education, adoption, and adherence. Recommendations for widespread promotion of the SBIRT process include educating the public about screening they can anticipate upon arrival to the ED and what that process entails, to increase compliance as well as reduce stigma. Additionally, the incorporation of the screening into the EHR system in order to streamline the process, increase efficiency, and increase nursing staff compliance with the protocol should be pursued. It would be prudent to incorporate reflective practices outside of empirical knowledge to identify gaps in the staff's understanding of the SBIRT process, as well as their assessment and understanding of the implications. The implementation of SBIRT in the ED demonstrated that a structured, evidence-based intervention can be successfully integrated into an existing clinical workflow and produce meaningful improvements in the identification and referral to treatment of individuals at risk for substance use disorder. Despite positive clinical results, future work should focus on replication in other settings. examining longitudinal outcomes, cost effectiveness analysis, improved efficiency, and strategies to increase community referral sources. Use of qualitative interviews to understand contextual barriers, patient and staff experiences, and to design refinements would be beneficial in future work. Thank you for taking the time to view and listen to my project presentation. The following slides are references used for this project presentation.